Hello, my name is Sam Felton and welcome to Expert Interviews here on Smash the Fact. Today, we're going to be talking with a general practitioner up in Gloucestershire, which is kind of in the West Country of England, and he is in a general practice and general NHS practice, which is absolutely amazing. Because he's really kind of getting involved with his local public and really changing things within the health system within his locale. It's Dr. Ian Lake. How's it going, Doc?
Hello, how are you? Very well, thank you. All going well here.
Fantastic. Now, I became aware of yourself because you came up to London to attend Health Unplugged, which is a conference that I was speaking at, and then we had a very nice lunch and a good chat. And you read my my book Slimology, and you said that you liked it, which is absolutely fantastic to hear from a GP particularly. And then I found out all this amazing information that you're setting up kind of weight management research projects and helping out with your local diabetes community and things like that. So before we kind of get into what we're going to be talking about today, which is treating diabetes and obesity as a GP, which I think is an important subject, particularly for GPs in practice at the moment, about how they can go about it, because it can seem overwhelming, the amount of information and the problem at hand. But how, firstly, did you kind of come to where you are today?
Well, way back in about 2007, 2008, I was established in a general practice and got to know my patients quite well, and it was apparent that we had no dietary advice for our patients. We had very few dietitians, and the ones that we had were linked really with the hospital system, and they hadn't really got any time to give very generalized information to patients sort of off the street, and all we could offer really at the time was commercial weight management groups. So I felt it was quite important that the NHS might be able to have an input to this, because as you know, and I'm sure most other people know, that prevention really, I know it's a cliche, but prevention is really much better than cure. And just before I got involved with that, 2 or 3 research projects were published, especially the Finland study, which most people have heard of, which were taking people with pre-diabetes, encouraging them to adopt a healthy lifestyle, which at that stage was really calorie reduction and increased exercise. And they got some fantastic results with huge relative percentage reductions in the incidence of new onset diabetes. So pre-diabetes patients were now non-diabetes patients. We could argue that's a remission stage or not, but it's compelling evidence to suggest that diet and lifestyle alone can actually make a huge contribution to the burden we're facing really of diabetes complications, which is every talk you go to on diabetes, somebody will reproduce the same old stuff, but it's billions of pounds per year that's going on diabetes, and it just seems completely ridiculous that we're spending a heck of a lot of money on a disease where we do have at least a chance, it's at a very basic level, of preventing this disease from happening in the first place, or certainly putting it into remission. Now, if you can put a disease into remission for a few years, you're gaining a huge amount of life for that patient. And most patients, if anyone's listening with diabetes, would prefer to have a mechanism by which they can actually manage it better or not have it in the first place. Unfortunately, once most people have it, you have to just deal with it really. And so that was really the background. It was frustration of not having anything to offer patients apart from medication really, and diet and lifestyle advice, which we couldn't give really because there wasn't any available. So I worked with TescoDiets to use their internet facility, their internet diet arm of their company, to provide nutrition advice and diet advice, and also use their practice nurses over a period of a year. We got good results. We got pretty much the same or slightly better, I suppose, than Slimmers World, Weight Watchers, etc. But it was in line with all of those. And at 2 years, we still had a can't honestly remember the percentages, about 30% of patients have still lost 5 kilograms in weight, which was, I thought was good. It was commissioned, but unfortunately it couldn't get a huge amount of engagement from Tesco's at the time, and it sort of withered on the vine, really. And it was a difficult website to use because it was an early example of a diet website, and now, of course, 5 years on, we've got far better websites, and things are much better. So that was a sort of transition phase, really, and it worked really well from my point of view. It showed me what can be done. Coupled with that, you know, day-to-day general practice, you do get quite spectacular results by engaging people in diet and lifestyle advice when they have a diagnosis of pre-diabetes. It's sticking at it that's the key, and giving people the advice that they can sort of use to sort of learn for themselves, really. You have to learn this yourself. There's no recipe book. You just have to, apart from yours, of course, in Slimology, but there's no major recipe book. People will have to get the basics and then go away and do it. Don't forget, in the NHS, even if you provide 100% of the tests that the Diabetes UK and the NICE guidelines recommend, that is testing feet, blood pressure, cholesterol, blah, 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 we're still only seeing patients 0.4% of their year. The patients are on their own 99.6% of the year.
Yeah, it's amazing.
You know, it's a big ask of your GP to actually manage your diabetes really well. So it's hugely important for people to be fully informed as much as we possibly can. There's lots of information out there, but there's still lots of new diabetes, and we've got to have to start working on diet. And I think, you know, I became interested in that as a result of my study and as a result of the Finnish study. And also, I must confess, I have diabetes myself. I've had type 1 for 20 years. So there's a personal interest in actually trying to understand the complications the complexities of this condition, really. Tantalizing to think that you can actually improve your chances by using lifestyle changes, and there's a lot of evidence, and a lot of people are doing a lot of good work and making huge progress, really, in helping people in the early stages and also some of the latter stages of diabetes. So I think it's exciting times, and there's lots of progress.
It is rather incredible. Now, last year, as you said, you've been a type 1 diabetic for the past 20 years, perhaps managing it kind of conventionally.
Absolutely.
But last year, I believe that you became aware of Richard Bernstein's work.
Yeah, about 2 to 3 years, actually. Yeah.
That was 2 to 3 years ago. And so then kind of last year is when you really started to delve into it.
Absolutely. I'm born and bred, you know, cut me and I bleed NHS. That's what I am, and that's what the public pay me to do. So I do the job, and the NICE guidelines, the National Institute of Health and Clinical Excellence guidelines, inform us as to the best work practice for doing the job. So we sort of have to follow that to some degree. However, I think there's always a tendency with us guys as physicians, especially to want to move on with treatment. So if weight management and lifestyle hasn't worked, which is right at the top of the algorithm, we're sort of quite quick to start medication. And once you're on medication, you've sort of taken the responsibility almost of the patient to sort of carry on with diet and lifestyle. It has to be reinforced all the time, really, how important diet and lifestyle is. And I think it's important to say, look, if we can get your weight and your diet as well managed as possible, whatever we've got left is the true condition which we have to treat, really, in a different way to weight management and lifestyle. But until we've tried those things, we're not going to know how much potential we have, how much potential the patient has to go into remission or to improve their overall control, which of course will give them a major advantage later on in their lives. So you know, it's very, very important. And Richard Bernstein, as you say, he was way ahead of his time, really, and he wasn't medical at the start. He was in industry doing something, and he developed diabetes, and things were getting worse, and he was actually, I think from his book, getting complications and renal complications and, you know, lots of protein. And he discovered for himself the diabetes diet that he uses, which is essentially a ketogenic type, Atkins type, paleo, if you like, type diet. And he's now complication free. He's had diabetes for 70 years. He's been injecting insulin for 70 years. And you can't just ignore that inflammation as a one-off, because he did have complications. And there's another study by a Japanese group where only published last year, I think it was in the Lancet, if you guys are interested, I can look it up, whereby 3 kidneys donors had diabetes were transplanted into patients who didn't have diabetes, and the kidneys that they used were all had diabetes disease or showed signs of early diabetes disease. I haven't checked exactly what the level of disease was, but all 3 of those kidneys reverted to normal when they were in a host that didn't have diabetes. So that is fantastic, isn't it? It's absolutely fantastic. It shows you can reverse things if you catch it, and that is so fantastic. It gives people so much hope, I think. And just to add on from that, another example which is also tantalizing is of course bypass surgery, gastric bypass surgery, where you're bypassing essentially the stomach and duodenum, the first parts of the bowel, and people say within weeks diabetes disappears. So we've got this so perceived chronic condition, a condition that's going to go on and on over years, and our model is that things develop over years, but we can sort of treat it in weeks and months. So there's something going on. It's not a total disease process. It must be diet related, surely. I mean, if you can take the load off the stomach and thereby the vagus nerve and the hypothalamus, the brain that registers all of these sort of neuropeptides in the gut, you can reverse diabetes quite quickly. It's not a long process over months and years, but it does start over a long period of time, seemingly. So that's how I came into investigating, well, what is it about our diet that might be modifiable to sort of improve people's chances? And of course, Richard Bernstein is a fantastic example. And there are a lot of examples in the literature, you know, and most people listening probably know about all of the sort of trailblazers. I mean, Tim Noakes from South Africa is a great example, isn't he? Yeah. Developed type 2 diabetes. He's an ultra marathon runner. He used to run an hour a day to try to get rid of his gut, and realized that he couldn't. And eventually he discovered the new Atkins diet, and that transformed his life. And he had the sort of, I think, genetic type of diabetes. He's a thin guy, really. Yeah. And the example in your book of Steve Redgrave, you know, when he won his 5th rowing gold medal, he had a little pot belly on him, really, standing on the podium, and nobody can accuse Steve Redgrave of not exercising, really. So
yeah, no, certainly not. He was training about 6 hours a day. So.
And of course, he was carb loading. That was the passion of the. He was carb loading to improve his athletic performance. So by that roundabout route, I came to the ketogenic type diet, and I decided to start it this year in earnest, really. I couldn't quite get my head around eating fat, and that's a huge step for me, because it's been ingrained in me over years and years and years that fat is bad for you. And of course, a lot of the research papers, you know, you can pretty well prove what you like now with diet. And most studies are observational, so they don't prove, they're not causation. They don't prove that it's the cause. It's just an observation, and that's a big roadblock, isn't it, to making any progress? And people are sort of quoting studies here, quoting studies there, and so I decided to go really right back to the biochemistry and spent 6 months having a look at that. And to me, the ketogenic type, certainly low carbohydrate diet, is what we should be using. I'm not in any doubt about that. It's not a theory for me, but it's not for everyone. You know, you have to choose your diet. I mean, I would say, and I can't remember who said this, but they said, well, if your body is showing that it can't handle carbohydrates, why are we putting them in the diet? I mean, it's as simple as that, really. If your car runs on diesel, why do you put petrol in the tank? It's as simple as that, I think. But when you get it, it becomes so obvious that you just wonder, well, why did it take me so long to understand this information? Especially, you know, embarrassingly for a health professional who has access to lots of these things, and that's our interest subject. And guidelines are slowly changing. However, over the last 18 months, you're starting to notice a row back or dominant sort of statement. They're very bold statements on, you know, it's got to be low fat. So it's just start to edge away without actually admitting that there's any mistakes have been made in their guidelines. But that doesn't matter as long as we're heading in the right direction.
Exactly. As long as we move forward, and I suspect that's what's going to happen. But hopefully things will start to change over the next year even more. But what really interests me, Doc, is, you know, how do you implement this style of advice that kind of counters NICE guidelines, but, you know, working as a GP? How are you trying to integrate that in your treatments?
That's fine. Well, at the moment, I'm a long-term locum doctor, just about to think about accepting a salary position to give me some stability with my patients. But I've been in the same practice for over a year now, and I know what, you know, who I need to sort of approach from the patient point of view. How I approach it is really thinking about. I use the New Atkins diet as an example. I think that's a good start, because initially, you know, the first few chapters describe what's going on in the intent, and the last bit is sort of a recipe really as to how people might approach it, and then they can add carbs in later. And I sort of cop out a little bit by saying, well, olive oil's all right, rather than fat, just to get people the confidence to feel they can get started. And it's really seeing them as regularly as you possibly can fit in the context of a busy general practice, really. In the future, I'm trying to negotiate some time to teach GPs and practice nurses about the ketogenic diet, or the low carb, high fat diet, the rationale behind it, and go through some examples of how we should be thinking about approaching diet. And I think once we've got everyone on board, we can start to make progress, and then we can start to implement a proper program, rather than this ad hoc program that I'm doing at the moment. But you do get good results. I mean, all the figures go in the right direction very, very quickly, and patients get very enthusiastic. It seems to be around weight loss, but it's general health that does improve. You know, all the markers that you look for in disease just get better very, very quickly, and you can't ignore that. It's anecdote. It's you know, one person. It's not a study. But studies of this type, it's very difficult to control a study where there's so many variables. So multiple anecdotes, fine. I think if you're getting results, and obviously you're getting good results, but I don't really think it matters if it's anecdote. If people are improving and everything's working for them, the diet's a little bit on the left of centre, but it's becoming more normalised. I think I'm okay with that. So we're going to do a study hopefully called Reboot My Body. It's really a regular meeting, a bit of education, a bit of chat about things, you know, just a standard stuff you find in any slimming clinic really, but with an emphasis on moving from carbs to really moving to low carb, low carb, and that includes the sources of carbohydrates, you know, wheats and rice, etc. I think we're going to start looking at that, and of course refined sugar, which is probably where the heart of the problem lies, with the very high quantities of fructose that we're taking in today. You know, fructose, as most people know, bypasses all of the regulatory pathways of the cell. So the cell is full up with energy, and it doesn't want anything else. So no wonder fructose, when the cell's full, why should it take in glucose really? There's no point. So everything backs up, and you get weight gain. You possibly then become more susceptible to the effects of high insulin, and then off you go. So I think, you know, we start with that approach really, and I've written several small articles as a discussion point around the whole holistic concept of living, rather than just what you should have for breakfast, things like that.
Yeah, because I mean, it is a complete lifestyle change, and I suppose like emphasis on that, and with this new study that you're hoping to do with Reboot My Body, that's going to be kind of a group scenario. Yeah. Will it? Because I think that's important, because last week we saw on Doctor in the House with Dr. Rangan Chatterjee up in Manchester, that he actually, within his clinic, within his surgery, does do group sessions like that as well. Kind of takes, you know, 10 people at a time, because, you know, you can only see each person for like 6 minutes or something. You could do that, or you can take all 10 people and see them all for an hour at once, which is incredible, really.
I think it's a good policy, and I mean, as you know, Dave Unwin, who's a GP up in Southport, so they're all up north at the moment, aren't they?
Yeah, it seems to be.
He runs the same sort of pattern, and I think from his approach, really, in his opinion, it mushrooms. People are so impressed with what's going on that they just tell their friends, and their friends turn up, and family get involved, and so teaching in small groups can have a huge sort of ripple effect very quickly. I think we just need a few famous people, don't we, to convert.
To really get behind this. But hopefully we've got some upcoming projects that will hopefully push that in the right direction for sure. Now we do have a couple of questions on the blog for you, and they're both in the same vein really. First one from Phil Thompson and the second one from Jennifer Douglas. Phil's talking about what's the best thing to do about elevated fasting blood sugars around the 6 to 7 range, even on a LCHF diet with less than 50 grams of carbs a day and less than 100 grams of protein. And then Jennifer, as I said, is kind of in the same vein, that her family seemed to have a genetic predisposition to insulin resistant, but despite following a low carb, high fat diet, her fasting glucose has kind of creeped up a little bit from 4 to 5.6, and that her mum is insulin dependent type 2, and often goes to bed with a blood glucose of 8, which is worrying for a start, and wake up with a 14 millimole blood glucose, which is rather incredible. So what should these guys be doing?
Well, I think in the second case, Jennifer, isn't it?
Yes.
Yeah. I think, if you've got a genetic predisposition, I don't think we understand it well enough really to make any more progress. Try really hard to just analyze what it is in your diet, and what are your eating patterns really. Are you eating too much later at night? I think that's a place to start, but I'm sure most people have already worked this out before they come see the doc. High sugars in the morning, I mean, it could be that the person's had a hypo in the night, which is probably unlikely, but it's possible, and you get a rebound hyper, or it just may be there's not enough insulin on board, and therefore the sugar's going up. So it may be a problem with sugar control through injecting insulin or other aspects of medication. That's clearly, I mean, I can't comment on that beyond that, because that's
you need a proper clinician to look into that, and ideally with a full kind of lifestyle diary, as I describe it, in terms of how much sleep you're getting, how stressed you're feeling, obviously what food you're having, and how much physical activity.
There are a lot of other elements, aren't there, in sugar control other than food, really. As you say, that there's sleep as well comes into it. I mean, there's a whole of the emotional response through the vagus nerve, through the hypothalamus in the brain, which probably governs most of our eating habits, and probably is responsible for organising all the gut hormones that we don't fully understand sort of how they interact, really. And the first question, sugar of 6 to 7, my experience, that's not bad at all. 50 grams of carbs, some people would argue that you might be wanting to head a bit further down on that. Fasting of 6 to 7 is not far out of the normal range, but depends how much control you really want. And of course, that may have a knock-on effect throughout the day. I don't know what medication you're taking, if any, or whatever, but some people advocate going right down to 25-30 grams of carbs for a short period of time just to see what happens. But again, it's just a general, really. It depends what sugars are doing throughout the day, I think.
Yeah, as well. And something also to try is certainly kind of tapered eating. So making sure that kind of your first half of the day is when you have your biggest meals, and then start to have smaller meals throughout the day. That seems to have a big effect on blood glucose levels as well. Along with some well-managed fasting with kind of a with your doctor's aid, kind of Jason Fung's advice on that is second to none, I think. Have you read up on Jason Fung's things? No, I'll have to send you that, all of his fasting protocols.
I think increasing your time between meals is a good one, really. If you're not on insulin, it's certainly easier. But there's quite a lot of evidence, isn't there, that increasing your time between meals, eating when you're hungry, etc., if you can do that with your current regimen of medication, is quite beneficial for diabetes, really.
Which is another thing that kind of goes completely against what we were recommending before. Before it was kind of like small meals throughout the day, but it seems that perhaps it's more kind of, you know, prolonged periods of time between meals.
I think it's exciting times, aren't they? Exciting times. I think there's lots to learn and lots of knowledge to put across to the mainstream medical sort of establishment. Really, I think if we can do that, we've made a good start, and it is changing slowly.
Definitely, absolutely fantastic, Doc. So people can follow you on Twitter and find out all your thoughts or ask you questions directly at ID Lake, I believe. Ideal. And that only leaves us one more thing to do before we wrap things up, and that's to hear a smash it out from Dr. Ian Lake, all the way in.
Just a second, before I smash it out, I just want to talk about some research that I'm trying to get underway with a company called Ubiome, which you might look up as U and then BIOME. It's all about the bacteria that live in the gut, and I'm trying to look at people who have pre-diabetes and how their gut bacteria changes if they go into remission or if they go into diabetes. So all that is required really is for people to provide a sample of their stools really via this company, and I can get some free test kits initially, and then provide one after they've either gone into remission or developed diabetes. So that may be something people might want to be interested in. But
how can they get involved with that?
Just send me a Twitter and I'll get started with that.
Awesome. So hit you up on Twitter. Amazing.
That's you know, in its early stages, but that's going to happen this year. Next year now. Next year.
Mm-hmm. Fantastic. So yeah, if you want to be involved in a study, indeed, you have to just be in and around Gloucester and Cheltenham, or?
Well, I don't think so. I think it can be done anywhere. It may be that as we get the sort of club started down here, we may be able to get enough people to want to consent to do that in Gloucestershire. But I don't think it really matters as long as we can get people, because they'll own their own data. It's just letting them have access to it so we can analyse it and try to work out what it is about their lifestyle that has changed their bacterial profile, if it does at all. But I think it will, because there's lots of evidence that people with diabetes have a different bacterial profile to people who don't.
Definitely. So yeah, if you want to be involved in that, if you're in the UK, hit up Dr. Ian Lake on Twitter at ID Lake, and then he'll send you through details for that, no problem. So yeah, as I say, there's only leaves us one more thing to do. That's to hear a smash it out from Dr. Ian Lake. So on the count of 3, I want you to shout "smash it out" to the camera. So 1, 2, 3.
Smash it out!
That's what I'm talking about. That is fantastic, Doug. So much appreciated. Well, again, thank you so much for your time today. Yeah, I look forward to seeing the results of all your research.
Thanks very much. Thanks, Sam. Bye-bye.
Bye.